Okay, well, there's lots to get through for this topic, and I'm going to try and select it to things that are a little bit more applicable to the surgical side. But let me start by just talking about the pathogenesis, going into the stage-for-stage management, which could take a long time, so we'll try and get through it as quickly as possible so we can get to more of the surgical aspects. We'll talk about the morbidities of the treatments that are out there, and then get into the indications for post-chemo surgery, and talk a little bit about PET scanning. But really, this is what I'm going to talk about. So this is the first copyright infringement of the talk. There will be more to come. Seminoma. Is this thing on? Oh. Seminoma is not that common a disease. You see it about 8,000 times a year in the U.S. And pure seminoma accounts for 25 to about 40% of the total germ cell tumors that occur. There's a limited role for RPLND, so these patients often get lost to the urologists as they go to the medical oncologist and radiation oncologist for treatment. We often get examined on this subject, but we very rarely see it in the clinic. There's been a lot of changes over the past 20 years in the management of pretty much every stage, and this is probably most significant in stage 1. Just to quickly review the staging, stage 1 involves basically the testicular tumor only with no evidence of metastases or lymph nodes. Stage 2 has a variety of lymph nodes ranging in size. 2A and 2B are somewhat similar, using 5 centimeters as a cutoff for when things get significantly bulky, which is stage 2C. Stage 3 involves metastases, and basically metastases to the lung are more manageable than non-pulmonary visceral metastases. So just quickly going through the pathogenesis, it's said that intertubular germ cell neoplasia is the precursor, much like CIS in the bladder, you could say, to seminoma. And then seminoma from there can differentiate into the other non-seminomatous germ cell tumors, embryonal yolk sac, choreo, teratoma. And as we all know, 15% of these can have syncytiotrophoblastic cells, which do produce beta-HCG. Here you can see the classic seminoma here with the sheets of cells, and there's 2 different syncytiotrophoblasts, these big ink marks here, that are the producers of beta-HCG in about 15%. If you get really high levels of beta-HCG, you got to be suspicious that there's non-seminomatous germ cell tumor there, and this never produces AFP. So if you get AFP, you got to treat it like non-seminomatous. 3 classic subtypes. Spermatocytic, I'm only going to talk about right now because it's really not a seminoma when you think about it. It's very rare. There's 4 reported cases of metastasis which aren't well documented. So basically, it's a benign tumor. Anaplastic seminoma, you hear a lot about being more aggressive or presenting at a later stage. Here you can see it's nuclearly pleomorphic. There's a lot of different shapes there, and there's a lot of mitoses, so it looks more aggressive. Basically, though, stage for stage, the prognosis is similar to classic seminoma. So let's look at seminoma versus non-germ cell tumors. Seminoma presents more commonly as clinical stage 1 at about 80%. Less than 5% present with distant mets, and there's subclinical retroperitoneal mets in about 15 to 20% of people that present with clinical stage 1. So from that, and I'm going to say this over and over again in this talk, you can intuitively say that if you have an orchiectomy with clinical stage 1, you have 80 to 85% chance of being cured. Non-seminomatous presents basically equally divided between stages 1, 2, and 3. And in clinical stage 1, you'll have a far higher degree of subclinical mets to the retroperitoneum. Systemic relapse rates, and this is after definitive therapy, for clinical stage 1 is about 1%, so you know you have a good chance of cure with conventional therapy. Clinical stage 2A, it's a little bit higher, 10%. Look at this compared to non-seminomatous, much higher recurrence rates after definitive therapy. Seminoma, by the International Germ Cell Consensus Classification, there's no poor prognosis category. 90% of people are classified as good risk, 10% are intermediate risk. For metastatic germ cell tumor, which is a third of people that present, is a poor prognosis to begin with, and only about half the cases are good prognosis. Now, I was just recently at the Career Pathways meeting, just to take a breath of fresh air here, and I learned something about marketing yourself. So, just wanted to point out Department of Urology. Be there, go to. I'd say it's actually more be there and or go to hell, because the long-term evidence just isn't there. So, just looking quickly at the management of seminoma, it's important to look at this closely because the cure rates are very high and the people are very young. So you need to try and reduce the morbidity of treatment as best as possible, because these people are living a long life afterwards. So the side effects of treatment are not going to turn you into a gigantic rabbit, but they might turn you into this old guy who's probably oligospermic. Just looking at some of the morbidities of these treatments, there's a lot of papers out there about different risks that you incur by getting treatment with either medical or radiation oncology treatment. So cisplatin carries about a 2.5 to 7 times risk of a major cardiovascular event with 10 years of treatment. And so that's 5 times the risk of someone that's young. So it's still not that significant, but much higher than if you're on surveillance. And then cumulative doses of etoposide for 2 grams per meter squared, each incrementally increases your risk of a secondary leukemia by 0.5%. So if you're getting multiple treatments, you got to wonder if you're putting yourself at risk for leukemia. Now, this chart basically just shows, and it's not a great chart because it's poorly labeled, but this is radiotherapy up here, and this is the chance of having a cardiac event. And you look at 10 years, it jumped significantly. The bottom line here is surveillance. So these are people that had no therapy at all. The intermediate ones, these are guys that have chemo or chemo and radiation. And you can see how these lines go up significantly. This is 16 years, and then at 18 years, radiation and chemo are way up at the top here. Looking at another paper, just talking about cisplatin here, and 20 to 30% get renal dysfunction, peripheral neuropathy, hearing loss, and Raynaud's phenomenon. Yeah.
These cardiac events, these patients getting mediastinal radiation?
Yeah. A lot of them. The direct effects of radiation to the heart are significant for occlusive disease, so it really depends on the dosage. But this is a totally pooled study, so there's a mixture of people getting infradiaphragmatic therapy and people getting mediastinal.
Most patients don't get mediastinal radiation.
Absolutely not, yeah. This is germ cell tumors. Yeah. Sorry, the details of these studies are it would take forever to get into them, and I'm just trying to briefly go over them. So, 15 years after radiation therapy, your standard mortality ratio goes up by 1.5, and almost 2 times for cardiac and cancer deaths. I'll mention that again in a little bit. So, clinical stage 1, 80% of your presenters, 15% to 20% have occult retroperitoneal disease, and 80 to 85% have been cured by orchiectomy. So, this is where you guys should all take a Voltaren suppository or something, because it gets painful. So clinical stage 1, I made this flowchart last night because I had like 20 slides on this and it was just too much. So I'm going to just briefly go through this. You got 3 choices after orchiectomy for treatment in this day and age. One is adjuvant radiotherapy, which carries probably the most morbidity but has the best results, 97% progression free. So this reduces your need, especially dogleg radiation, reduces your need for surveillance with CT. So if you live in the boondocks and it's not going to happen, it's not a bad idea to get this done. The recurrence rates within 2 years have near 100% cure with chemotherapy. So if you do have a recurrence, your prognosis is really good. And if you have an inguinal recurrence, because you've had previous inguinal surgery or something like that, you can get radiotherapy again. Follow-up is the easiest follow-up to do is just chest X-ray and serum markers and CTs every 6 months. Single-agent carboplatin is a little bit more difficult because it's still considered experimental, but in pooled studies of over 1,000 patients, there's been no deaths reported. 2 cycles look like they're probably going to have lower recurrence rate and are well tolerated. The disease-free survival is equivalent to radiotherapy at 3 years. And even for advanced seminoma, there's a significant response to carboplatin. Surveillance, which is now tending to be the more gold standard treatment for people that can be surveilled. As we talked about, 80-85% cured with orchiectomy. Platinum-based chemotherapy for recurrence has greater than 90% cure for metastatic disease. And you can also treat recurrences depending on where they're located with radiotherapy for good cure rates as well. And if you had recurred after that, you could get chemotherapy. So, and any recurrence that occurs outside of the retroperitoneum after radiotherapy, you get chemo. So just looking at the downside to these treatments, radiotherapy, you can have recurrences in your clavicular fossa, supraclavicular fossa, mediastinum, your lungs. There's hematologic toxicity from the radiation, and GI toxicity is severe, and about 2% of people get chronic dyspepsia. The scatter dose is sufficient to cause persistent oligospermia. So these people are often infertile afterwards. And the cardiac toxicity and malignancies we talked about earlier. Carboplatin is a lot better than cisplatin, and this has been proven in a lot of studies with regards to all the toxicities. There's a decreased time back to work, and only about a 4% grade 3 to 4 hematologic toxicity, which is leukopenia. And the problem is that it's still investigational. You got to counsel your patient. There's a lack of long-term data. Most of the studies only go up to 3 or 4 years. But once again, they show equivalent results to radiotherapy at that time. Surveillance, it's difficult. Serum markers aren't helpful. The history of natural history is very indolent, so you got to follow these patients for a long time. 2 to 3 of them, or percent of them, will recur after 4 years. So, you can't just let them fall by the wayside. A lot of them will present as well with bulky retroperitoneal disease, which is a bit more of a problem to treat. And it's more expensive to surveil these people. Are getting CT scans every 4 months, so it's significant. Now, I couldn't give a talk without going through the annals of the BC literature here, and looking at a paper by Dr. McCracken, looking at the numbers from 1942 1978, published in 1980. Good numbers, 362 people, 87% cure overall, which is pretty darn good. Anyways, the interesting thing I found here was that the incidence of other cancers was not increased. So they were doing something pretty good, I think, back then. Either that or the general rate of cancer was much higher.
Thank you very much. I almost assumed the second one.
Okay.
Wait 15 to 20 years to see the absence of the secondary malignancy.
Okay.
We should have to follow the patients now.
Okay. I'll get into that if you want. Oh, okay. There's disagreement as to the fact that these cancers were not increased, and it's more likely to actually be a fact that they weren't followed. So just getting into the risk of malignant neoplasms. So these are all germ cell tumors, but about over half of them were seminomas, and in a huge population-based registry, the overall risk of secondary malignancy was 1.4 times, leukemias being the number one. So if you look at seminoma as the top curve here, so if you have seminoma over other non-seminous germ cell tumors, after treatment, be it whatever it was, you're at much higher risk to get a secondary malignancy. And this is a chart of the different malignancies they found, and clearly these ones here are the most significant, and that's the acute leukemias. Sorry, this mouse is not working very well. You can see you have an overall increased risk factor of 3 and 5 with a significant confidence interval there. So those are the big two I think you got to worry about. Also, stomach cancer, esophagus cancer, all significantly elevated.
Actually, a rare tumor, getting a 2 or 3 times increased risk of a rare tumor is still a rare tumor. So getting a 0.5 increased risk of a common cancer like colon cancer really increases the numbers, the actual absolute number of patients. It's not just the relative increase, the absolute.
I think it's important to point that out, as well as, the cardiac risk factors as well. These are 10 times increased risk or whatever the number is, and that's times a very low risk. So, it's not like everyone's going out and having a jammer and dying. So there's just a few controversies in the way that these treatments are implemented that I was going to point out. There's dogleg therapy versus a para-aortic strip. Well, not a controversy. Everyone's tending to lean towards para-aortic strip these days. There's a very small risk of pelvic recurrence if you don't radiate down onto that dogleg side. And this does, however, increase the surveillance because you got to look for that. Yeah. What's a jammer? Oh, it's now. It's an MI. Yeah, it's a slang term. This will definitely increase your chance of getting a wedgie, though, too. Okay, so then now they're looking at giving less radiation. 30 gray was the gold standard. Now they're looking at giving 20, and I think here they're actually giving 15 on occasion. And the relapse-free rate of survival is roughly the same. The toxicity, though, actually it's less in the early stages, but from what I've read, around 3 years, it tends to even out. So this I thought was a really interesting paper. So yeah, so everything I'm presenting here, any of these early papers, you're not going to know the long-term outcomes, for at least 10 or 15 years, because as well as the outcome from seminoma because of the late recurrences. So keep that in mind as I go through. So say you're a medical student, you're trying to get into residency, you got this big lump on your testicle, but you don't want it to affect your chances of getting into a good urology program. So you're carrying it around in a wheelbarrow for like 2 years, and then finally you go see the urologist after you match. So they take it out and they say, okay, you're going to go on surveillance. And you just think, well, this thing's been there for so long. Anyway, how am I going to know if I'm going to recur? So in a big study, 638 patients, they looked at risk factors for recurrence in clinical stage 1. So if you look at tumor size, red ATestase invasion, lymphovascular invasion, and anaplastic versus classic, these all looked to be significant predictors of relapse. But this is univariate analysis. When you pull these all together as risk factors, only 2 of them really stand out. So you have red ATestase invasion and tumor size greater than 4 centimeters. And if this mouse worked, I could point here. So red ATestase involvement, yes or no? Less than 4 centimeters. So no red ATestase involvement, yes red ATestase involvement. Not really that significant a difference. 85% relapse-free, 87.8% relapse-free. Big deal, right? So you look at, in the no side, greater than 4 centimeters, less than 4 centimeters, 83%, 87%, a little bit significant, but not that bad. But look, if you have red ATestase involvement and a tumor greater than 4 centimeters, you have a significantly greater chance of relapse. And I think that's important to keep in mind if you're going to go put someone on surveillance. Here's just a graphical demonstration of that, where this is tumor greater than 4 centimeters, and this is your chance of progression-free survival. And you look at this side, sorry, not survival, this is just progression-free. If you have red ATestase involvement, you're down here, so keep that in mind. Who are you going to treat? Well, 21% of patients that have both risk factors are the optimal candidates for radiotherapy because they've got a very high chance of relapse. And 80% of your patients, by these criteria, will be good candidates for surveillance. And overall, through the magic of mathematics, 70% of people will avoid therapy altogether. Unnecessary therapy, that is. Looking at single-agent carboplatin, there's a study comparing this to radiation. And this is what I was saying earlier. They show the same survival rates, relapse-free survival rates, sorry. And in this study, there was only 1 death in the radiotherapy group that wasn't really specified. So if you have clinical stage 1 and you're not a candidate for surveillance, adjuvant radiotherapy is the gold standard of care. So if you're going to try and use single-agent carboplatin, you really have to counsel these patients about the lack of long-term data. Okay, so I got one more thing. Career pathways. this meeting about learning how to market yourself. You always want good people or people to say good things about you. So that's my. Okay, moving on.
Can you comment on the Carboplatin? I don't think that's
Carboplatin actually really does what? We're actually doing stage one. And that's because of the risk factor.
it's 2 courses.
We're using 2 courses for now. And the MRC trial used 1 course. And they got data at 3 years. Median follow-up showing that it's equivalent. But we're using 2 for now until there's a German trial. Christian can comment on that. See whether the 2 there's 2 cycles for versus radiation. And so until we see that data, because there's some data that suggests retrospective that 2 may be better than 1. But it's different though. It's hard to think of different right now.
So if I was a patient and you were offering radiotherapy or 2 courses of carbo, what would the patient?
Well, you already said you were radiotherapy for a young guy. For a young guy that's got a risk of that second for 20 years, we're moving more towards at a surveillance and carboplatin.
There's actually a second study, I think it was technical study, which essentially they prospectively allocated patients to either surveillance or 2 cycles of carboplatin based on the risk factors each have presented. Around the risk factors. If patients had 0 risk factors, they were put on surveillance. If they had 1 or 2 risk factors, they were put on 2 cycles of carboplatin. And that's actually showed also a risk of recurrence of the 2 cycles of carboplatin of about 2 to 4%. And then there's currently a German study which has completed full compared radiotherapy versus 2 cycles. And there's a series of phase 2 studies with mature follow-up, 6 to 7 years median follow-up, which used 1 or 2 cycles of carboplatin. And if you look at the data, they all have a 99-100% overall survival. But the relapse rate in the 2 cycles, 2 carboplatin cycles, could seem to be in the range of about 1 to 2%. So that's why we currently use 2 cycles of carboplatin.
But that 1 versus 2 from retrospective.
No, that's just 2 cycles.
One cycle, the only one is they're using a lower dose, they're using milligrams per square dose.
Yeah, because some of the studies are already
Okay, thanks. We're going to try and keep things moving as best we can. At the end, we should have some time to talk. Just to summarize for maybe the urology residents that aren't as familiar with seminoma, to summarize clinical stage 1, you have 3 options. One is surveillance, one is radiotherapy, and one is now single-agent carboplatin, which is still considered experimental. Surveillance, I think, is being done probably in about half of people that are presenting in BC, is from what I've heard. And this involves a pretty strict follow-up regimen. So if your patients aren't going to tolerate that, you got to think more about doing radiation therapy or experimental carboplatin. Okay, so moving on to stage 2, as I said before, this is all about the size of your nodes. So if you're over 5 centimeters, you're in stage 2C and you're going to get different therapy. 2A, 2B, radiotherapy to the retroperitoneal lymph nodes is very effective. You're looking at 25 to 30 gray with boosting 5 to 10 gray to the areas that are affected. Late GI toxicity in about 8 to 10% people, but otherwise well tolerated. Relapse rate for 2A, 2B down on the bottom here. You can see they're quite low. For 2A is up to 8%, and 2B is, that should say 13%, 10 to 13%. Stage 2C, the most important factor here on how you're going to do is the amount of bulk that you have of these lymph nodes. Dogleg radiotherapy was abandoned recently because the recurrence rates were just too high. And you can see by the rate of recurrence with, this is progression-free, 44% with radiotherapy compared to 95% with systemic chemo. The problem with treating people with systemic chemo is if you recur after that, you're in a totally different category, whereas if you recur after radiation, you can still get chemo. The problem with giving radiotherapy before chemo is that the radiotherapy can really suppress your marrow, and that can confuse your chemo significantly. So they say in this study, I think it's out of Toronto, if you have a solitary mass less than 3 centimeters, which is 2A, 2B, so they recommend radiotherapy. Anything over 3 centimeters, if you have multiple masses or you're having symptoms from the masses, then induction chemo is the way to go. Why would you use systemic chemo in 2A, 2B? Well, if you have really lateral masses and you're going to have to radiate really wide, there's a lot of radiation to your kidneys and your liver that is better to avoid. Okay, so getting through stage for stage here. Advanced seminoma or stage 3. Less than 5% of presenters will be like this. There's a lot of goodness about the risk factors and whatnot that I'm going to skip over here. If you have the worst case scenario, which is non-pulmonary visceral Mets, your overall survival is still around 80% with 75% of people progression-free. This is really the only thing that the UICC recognizes as prognostic. Other groups recognize previous chemo as prognostic in this group. Treatment for good risk or 3A would be 4 cycles of EP or 3 of BEP. Non-pulmonary visceral Mets, 3B. You want to do full induction chemo with 4 cycles of BEP. Carboplatin equals worse survival, so it's not commonly used in these groups. Relapse after this. So 10 to 15% will relapse after induction chemo. 10% will have a late relapse or relapse after a complete response, and that confers a poor prognosis with long-term survival rates less than 50%. And salvage chemo for these people is difficult for them to develop because there's just not enough patients to try and get novel regimens underway. Okay, so now moving into the indication for post-chemotherapy, which is why you guys are all still here. After first-line chemo, so this is people that present with retroperitoneal masses, and they get chemo. After chemo, there's still going to be up to 80% of them that still have detectable masses, right? So what are you going to do? In non-seminomatous, this is when you want to do surgery because there's a high incidence of teratoma, which, as we all know, is not going to respond to chemo. And that can be found, or viable germ cell malignancy period can be found up to 20% of these masses. Seminoma is more difficult because the masses contain viable cancer in 10 to 20, but probably favoring 10% of the cases overall. About 90% of these masses will be necrotic. It's hard to tell which is which. So surgical resection is very technically difficult because they're all post-chemo and they've got this diffuse desmoplastic reaction, and the surgery is very morbid. Moreover, teratoma is very rarely observed in these patients. So you got to keep that in mind and stratify your treatment options for these patients. Observation, resection, or salvage chemo, which you'd only do if you were sure that they were relapsing. So post-chemotherapy, radiotherapy has really no role in the management of these residual masses. There have been multiple studies that have shown that it's only increased morbidity and not actually led to significant cure rate. Observation, the pros for that is basically the cons of surgery, which is that it's morbid, and the fact that you know that 90% of these masses have no viable cancer in them. You'll notice if you do observation that 50 to 60% of these masses will actually resolve, and the median time for this is 13 to 18 months, but it can go up to a couple of years. And this protracted time course makes it difficult to make these decisions because every 6 months you're looking and nothing's changed. The most important thing that they've found over the years is an actual size cutoff. So if you have less than 3 centimeter post-chemo mass, you have virtually a 0% chance. I know it says 0 to 4, but if you look at all the studies, it's close to 0% chance that there's any viable tumor in there. I'm going to contradict myself later, but I'll say that now. If it's over 3 centimeters, then there's a significant chance that there is viable tumor in there. Up to 40% of greater than 3 centimeter masses will have viable tumor in them. So let's just look at PET scanning for a second. And it's a sign that I saw. It's not funny, sorry. PET scanning has been looked at in prospective randomized trials looking for viable seminoma. This is the biggest one that I could find. And positive scans were more predictive than the 3 centimeter cutoff, with 100% specificity and a sensitivity of 80%. So if you looked at 44 patients, as they did in this paper, 44 of the patients in that paper had a negative scan, and 2 of these patients were later found to have viable seminoma. So that accounts for that sensitivity problem. Funny enough, both of these 2 masses were less than 3 centimeters, which is my contradiction from previous, because less than 3 centimeters has a very, very low risk of carrying cancer. So there you go, I contradicted myself. PET scan is definitely a useful tool for characterizing these masses, and I think, from my understanding, is actually the gold standard for imaging these patients. So if you can feasibly resect something with a positive PET scan, you should. And I'll talk about the evidence behind that in a sec. Observation can be justified if you have a negative scan. And this is even more so if the size is less than 3 centimeters. It's another contradiction, I know. But there's no role for PET scanning in non-seminomatous because the risk of teratoma is too high and it won't light up in the PET scan. So resection versus surveillance for post-chemo masses. There's really no good evidence to support either. These numbers of these patients are so small that to power a study is virtually impossible. The other thing you got to keep in mind is that even resectable masses or masses where people have gone in to try and resect, only 58 to 74% of them can actually be completely resected. And this is the biggest study I could find about this, and this is from MSK. 55 post-chemo masses. And this is going to get a little bit complicated, so I'm going to slow down. So 27 patients had a greater than 3 centimeter tumor that was resected or biopsied. So some of them couldn't be resected and they were just biopsied. Overall, 30% of these patients had tumor. So this is exactly what I told you before, about 30% of greater than 3 centimeter masses are going to have viable tumor in them. 6 of them were seminomas, and funny enough, 2 of them were actually teratomas, which is somewhat more rare for seminomas, more common in non-seminomas. So of the patients in this study, 28 with less than 3 centimeters, they were all necrotic, closer to the 0% chance of viable tumor with less than 3 centimeter tumors. So of the 8 people that had viable tumors, 6 of them were well defined, and they were completely resected. And at 4 years, these patients were still alive. The 8 tumors that were not well defined and could not be completely resected, these patients died. So this is really the evidence to support that there's actually a therapeutic benefit to resecting these masses, although it's not entirely clear. 26 of the patients that had a complete resection and subsequently the mass was found to be necrotic had a relapse and died. So having necrotic masses is not also that prognostic. You can still have a late recurrence and die. So, conclusion from this is that any residual mass smaller than 3 centimeters can be observed. There's going to be no benefit from doing surgery for these patients. Residual masses over 3 centimeters, surgery is preferred if it's feasible. And this helps define the response. It helps resect viable tumor when possible and maybe confer a therapeutic advantage. And it also helps direct further treatment by getting actual tissue from these. So, when this happens, you need to get everyone on board and make a decision in a multidisciplinary approach. Yes, it's too young, eh? Reference is too young. Okay. The summary from this entire talk. Okay, seminoma has an indolent natural history, very exquisitely radiosensitive and platinum-based chemotherapy sensitive. Dogleg radiotherapy has been the standard of care for stages 1, 2A, and 2B for years and years. And overall survival rates for all presenters is close to 100%. Surveillance is an acceptable alternative and is becoming the gold standard of care when it's feasible. Single-agent carboplatin is up and coming and may give radiotherapy a run for its money when the long-term results are available. Bulky retroperitoneal disease or any distant mets means induction chemotherapy, and we talked about that. Overall survival rates for metastatic seminoma is over 90%, which is impressive. So many residual masses over 3 centimeters should be resected, and PET scan is going to give you more direction as to whether or not these can or will contain viable germ cell tumor. And you got to keep in mind, if it's technically feasible, there's no real advantage to doing an RPLND if you can't resect the mass. Salvage chemo confers a diminished survival. So if you have a post-chemo recurrence and you get salvage chemo, your survival rate is going to be 20 to 50%. Residual masses can be safely observed if they're less than 3 centimeters, and particularly if they're PET scan negative. So that concludes my talk.